This is the patient sleep questionnaire that the patient completes on their own. Most labs have their own variation of this, so the layout of it might be slightly different. The type of questions or the way they're asking the questions are slightly different, but the basic premise behind it is pretty much the same. So the first section is what the patient's main sleep complaint is. Whether they're having trouble sleeping at night, how they feel the next day, if they're sleepy or tired, whether they feel like they're very restless throughout the night, or what other else concerns that they might have in regards to their sleep. And this is in their own words that they're putting this down. Then we also want to take a look at how long has it been going on? Months, years? Is it an acute issue or is it chronic? Does it correlate with a certain life event or life change, weight change, something like that? To kind of really more pinpoint down what might be going on. We look at their sleep patterns, so what their normal bedtime and rise time is, not only on the weekday, but a weekend. So does the patient even give themselves enough time in bed during the weekdays, or are they creating a bit of sleep deprivation by staying up late, having to wake up very early, and are compensating for that on the weekends? Are they maintaining a fairly consistent sleep and wake time across all 7 days of the week, or is there a large variation between when they're working and when they're not? How long they feel like it takes them to fall asleep, how much they feel like they wake up throughout the night. That's all important information. How many times they nap per day on the weekday or on the weekend. And then we can further kind of jump into that and look at are those naps intentional or are they unintentional? Meaning, are they laying down and purposefully trying to take a nap during the day, or are they unintentionally nodding off, say when they're watching TV or something, or sitting quietly or something like that? The unintentional naps are more indicative of an underlying sleepiness that they're feeling versus if they're intentionally laying down in the afternoon. The bottom section is the patient's usual sleep habits. So we can kind of get an idea of what their typical pattern is, whether or not they watch TV or read in bed prior to sleep. Do they eat during the night if they awaken? That's fairly abnormal and could be indicative of a nocturnal eating disorder. Whether or not they awaken during the night to urinate. Now that's not abnormal, but sometimes if they're waking up a lot to go to the restroom, it could be maybe they have some other underlying issues that need to be further investigated. Do they wake up throughout the night, or at least do they realize that they are waking up throughout the night? Do they have trouble going back to sleep after they wake up? How do they feel when they wake up in the morning? Do they feel tired, not refreshed? Do they have nightmares as an adult? Now, nightmares aren't abnormal. We've all had nightmares before, but if they are happening with relative frequency, then it could be maybe they have some underlying nightmare disorder in relation to a traumatic event, something like that. Do they sweat during the night? Most people do sweat during the night. That's why you'll find the temperature at the sleep labs is kept cooler. But if the patient knows that they tend to sweat a lot throughout the night, I'll probably really try to get that thermostat down lower and make sure I have fans ready to go in case that I do need to flip on a fan, because when somebody does sweat profusely during a sleep test, what can happen is it can obscure what you're looking at and cause a lot of artifact in your signals. The bottom one is whether or not the person can sleep on their back. Now, whenever I see that that's checked, it always warrants further questioning on the patient. So do they have trouble sleeping on their back because it's uncomfortable, or do they have trouble sleeping on their back because they can't, because of some type of underlying injury or something like that? Most sleep labs do require or request that you try to get supine sleep. You try to get the patient to sleep on their back for at least a little portion of the night, so we can see if there is a big difference between sleeping on their back as compared to their side. If a patient has some type of injury that prevents them from sleeping on their back, if you're going to want to document that, because you won't be recording supine sleep. If it's just uncomfortable for them to sleep on their back, then yeah, we're still going to request that of them. And most likely, if it is uncomfortable for them to sleep on their back, it could be because they have more of a supine related issue when it comes to their disordered breathing. We'll go on to the next page. So the top section that asks all the questions about the breathing, that is really in relation to whether or not the patient has an underlying sleep disordered breathing. Can you see it all? Let me try backing it up. It could be symptoms of OSA, whether or not they stop breathing during the night, waking, gasping, choking for air, that they snore, that they waken themselves up because of their snoring. This is kind of the very basic and common clinical picture that you see when a patient has OSA, obstructive sleep apnea. The next section, are they a restless sleeper? Do they kick and jerk their arms or legs during their night? That again could be indicative of an underlying disorder, some type of sleep disorder, specifically a breathing disorder, OSA. If they're stopping breathing continually, then they could be kicking themselves awake, really kind of flipping and flopping all over the bed to try to get to a comfortable position where they can keep breathing. That third one, where they experience tingly, creepy, crawly sensations as they're trying to fall asleep. Usually that is the typical complaint of patients with restless leg syndrome. Do they experience leg cramps during the night? That could be an underlying leg cramp night disorder, movement disorder. That would warrant further medical intervention or investigation. The behavioral sleep disorder. So whether or not the patient talks in their sleep. Talking in their sleep is normal. It's benign. We pretty much all do it. Do they sleepwalk? Sleepwalking isn't so normal as an adult. So as a kid, it's normal, but generally as adults, once you start to, you kind of age out of that issue. Does the patient grind their teeth during the night? Most patients know whether or not they grind their teeth because their dentist will have told them. It's really quite visible on when they go to get a dental visit. Do they act out their dreams? When a person says that yes, they do act out their dreams, that's going to make us start thinking, do they have an REM behavior disorder, which is where you do act out your dreams. When somebody checks that they act out their dreams, what you're going to want to do is to enact special precautions to make sure that this patient is safe during their sleep test, which would mean bed rails. You want to make sure the patient doesn't, if they are to start acting out their dreams, they're not going to flip and flop themselves out of the bed onto the floor. The vivid dreamlike scenes prior to falling asleep, the muscle weakness with emotion, the muscle weakness or paralysis, those last three under the behavioral components all kind of point towards possible narcolepsy. So when you have somebody that checked either any of those three, you are going to immediately start thinking, do they possibly have narcolepsy? So should we do the specialized test that tests for narcolepsy? Do you smoke, drink, caffeine? We want to know these habits, tobacco, alcohol, caffeine. Are they abusing, misusing any of this? What's their typical habits with this? Oftentimes they'll ask for the marital status and what their sleeping situation is, just to get a better idea of what this person's stress level is, or do they have a support system in place, and what their typical sleeping pattern is. Do we have somebody that we could ask about some of the things going on that's while they're sleeping to get some of that bed partner info. Their medical history, so their height, their weight, their neck size, what allergies they had, basic information, basic vital signs, what their weight was a year ago, what it was 5 years ago. So if there is a significant weight change, say they've gained weight, 5 years ago their weight was 50 pounds less than what it is now, one of the things that you could really further investigate is, well, did you have a lot of these complaints back then? Or is this issue probably came on with the weight gain? Medications, always important to have an accurate, up-to-date list of medications. And then also just going through their previous health history, diabetes, Do we need to make sure that we have snacks or juice available if the patient has diabetes in case if their blood sugar drops? Stroke. Sometimes you might see some issues, further issues with their breathing when somebody has cerebral issues like stroke or traumatic brain injury, things like that. Morning headaches is a typical side effect of having obstructive sleep apnea when you have those swings in your oxygen level. Do they have kidney disease, liver disease, hepatitis? So that would require the physician to have really close monitoring of the medications that they're taking. Tuberculosis, acid reflux. So patient checks that. One of the things that you might want to keep in the back of your head, does this patient need extra pillows to kind of sit them up a little bit more so that they're not lying so flat, to help with the acid reflux and keep the acid in the stomach? Because when a person lies down, you no longer have gravity helping keep that acid in the stomach. Heart problems, heart attack, irregular heartbeat or pacemaker. Just make sure it's helpful to know all this ahead of time, just so that you know what you're kind of in for with this patient's clinical history, but also to really make sure that you're very closely monitoring their EKG. High blood pressure is a common one, goes hand in hand with OSA. Does the patient have sinus problems or congestion? So this is especially important with if they're here for a titration study, where we'll be fitting them with the mask and they're going to be breathing with the CPAP. If they have sinus problems or nasal congestion, we might need to start thinking more towards a full face mask versus nasal. Also, the sinus problems, nasal congestion, uvula, large uvula, tonsils, or adenoids, that more points us towards thinking that they have more of an anatomical predisposition to OSA. Do they have a history of seizures or epilepsy? So these patients that have a history of epilepsy, one of the things you might want to think towards is, number one, bed rails. Make sure that patient is protected. So if they were to have a seizure during the night, again, they're not going to flip themselves out of the bed. But also, do we need to add additional electrodes to these patients to better visualize where the brain abnormalities are occurring, or if there's any abnormal brain waves going on, where they might be more localized? Anxiety. So is this patient nervous? Should we take more time explaining things with them? Maybe alter our approach with how we're treating this patient to help accommodate their nervousness or anxiety. Is it help if they're in a room near a restroom or a room near an exit, that type of thing? Emphysema, lung disease. So that could point you more towards making sure that you're monitoring their oxygen levels very, very closely, because these patients tend to have lower oxygen levels. Arthritis, fibromyalgia, those are chronic pain conditions, which can significantly disrupt a person's sleep. But the other thing you want to think about is what medications they're taking to treat that chronic pain. So a lot of times those pain meds can cause rise for fall precautions, because they can be heavily sedating. So if they get up throughout the middle of the night after they've taken one of these medications, they might be unsteady on their feet. So just pay attention to that. Chronic headaches, depression, well, again, just part of the bigger history, bigger picture. And asthma. So one of the things we'll cover later on is talking about asthma. And asthma tends to be worse at night just because of our autonomic nervous system. And so also the medications used to treat asthma, the inhalers, tend to have a excitatory effect. So something to be mindful of when a person that has asthma that has to take a medication, if they're having an exacerbation of their asthma during the night, that they might have trouble falling back asleep. Anything else that is pertinent that isn't listed there, the patient can list there. We want to know, have they had a previous sleep study? What was the outcome of that? Have they ever been on CPAP? Have they ever had surgery for a sleep disorder? What medications have they taken to treat sleep medications, either prescription or over the counter? Any surgeries they've had within the past month or year? And again, it all could come into play with what we're doing with this patient or what type of study we might choose to do for them. Epworth score, kind of just get an idea of their sleepiness level. Most labs always Epworth is a very common scale that a lot of labs are using. The bed partner questionnaire, so if possible, it's really helpful to have the bed partner complete this and compare what is the bed partner's, what are they perceiving the patient's issue to be, and what is the bed partner's thought on what the patient's sleepiness level is by having them complete the Epworth on the patient. Is it pretty much spot on with how the patient feels, is evaluating themselves, or is there a little bit of a difference? It's always interesting to see what somebody else has to say about you, because sometimes you really can get a lot of really good information from the bed partner if it's available. So yeah, so that's the questionnaire. You want to really make sure that you're going through it, trying to pick out the pertinent info of whatever's possible, and that you are tailoring any precautions that are necessary based on what you're reading throughout the chart. That the test being ordered is pertinent to the patient history, that you have the right test or most appropriate test being done, completed on this patient, and that you're also just giving them the best quality care that you can based on the information that you've been given. Thanks for listening.